Good morning, everybody. I am Antonio Pesenti from the University of Milan, and my talk today is about respiratory physiology and lung imaging. These are my conflict of interest, uh, which are not really relevant with the discussion of today. Now, let's see what is happened with the imaging in ARDS. We started in 1967 when Asbach defined ARDS using, between other signs, the chest X-rays. And we grew up with the idea that ARDS was a diffuse disease of the lung. This imaging has evolved from the plain chest X-ray to CT scan, and then positron emission tomography. And at the end, we will discuss a little bit about electrical impedance tomography. So let's proceed. CT scan was applied in ARDS in the mid 80s after an idea of Goran and Stierna from Sweden. We applied it in Milan, and we discovered that ARDS was actually not an homogeneous disease of the lung, but the lung was affected in a patchy way, with areas of collapse and areas that were still being ventilated. And that was a very important change because by using CT scan, we could, as an example, measure the weight of the lung. And then we had a quantitative uh, estimate of the lung edema and then of the severity of the disease. And it became immediately obvious that the weight of the ARDS lung was almost 2.5 times, sometimes 3 times the weight of the normal lung. And water edema took the place of air in the lung. We could measure the amount of tissue normally aerated and the changes in normally aerated tissue when we applied PEEP, as well as changes in PO2, changes in shunt, and the increase in normally aerated tissue was mirrored by the decrease in tissue densities. So in a way, were able to measure in grams the amount of lung being recruited by the increase of PEEP. Being next again, being able to measure the amount of normally aerated tissue, we discovered a very important thing, that is that compliance of the respiratory system was related to the amount of normally aerated tissue rather than the amount of disease. What was important was the amount of lung that was still aerated. And so we put forward the idea that in ARDS, the lung is not stiff, but is rather small. Just a small portion of the lung is being ventilated. And that was called by Luciano Gattinoni the baby lung, the baby lung in an adult body. And that was and is a very important concept of which we'll see the evolution. The other important application of CT scan as far as physiology is concerned was and is still it is possible to verify whether moving the patient from supine to prone, we actually can increase the amount of aerated lung. Uh, we know that proning patients, particularly severe patients, increases survival, but at this time we do not know yet the exact mechanism by which this improvement happens. And I think that CT scan in the future may still offer some additional explanation on which patients are responder and which are not. The next important use of CT scans in ARDS relates to the measurement of the recruitable lung. Lung to be recruitable needs to be collapsed. So the lung patients that are more recruitable are those that have more collapsed lung. That is, recruitable patients are those that have the most severe impairment in gas exchange. And Gattinoni once again divided ARDS patients into recruiters, good recruiters, and non-recruiters. On the bottom, you can see a patient that does not recruit, going from 5 to 45 centimeters of water, while at the top, you see a patient that goes from 5 to 45 recruits a lot of lung, a lot of air gets into the lung, and alveoli open up. This matches another important concept, which is the concept of atelectroma. In this slide, you can see on the top a patient that is a good recruiter. It means that when he starts from 5 of PEEP and goes to 15 and goes to end inspiration at 20 of pressure, he opens up a big amount of lung, while when he expires, the same amount of lung collapses. When we move at 15 of PEEP, the amount of lung still, some lung gets open and closed between expiration and inspiration. This opening and closing is supposed to be very dangerous for the lung, contributing substantially to ventilator-induced lung injury. On the bottom, you have a non-recruiter patient in which PEEP does not affect substantially the opening and closing between end expiration and end inspiration. This might be an important concept in talking about the atelectroma and ventilator-induced lung injury. Next, I'd like to talk about positron emission tomography. Positron emission tomography identifies in the lung areas in which the granulocytes accumulates tracing glucose. And so topographically describing where inflammation is. And you can see here two different patients, one with diffuse inflammation and the other one with inflammation located just on the collapsed zones. The next important concept is that even aerated regions are indeed inflamed. And here we could see that inflammation in the aerated regions is related to to the ratio of tidal volume to end expiratory lung volume. So it's not the absolute size of tidal volume that counts, but the ratio between tidal volume and end expiratory lung volume. This basically is the concept of driving pressure. The last thing I want to talk about, a very powerful instrument to study ARDS physiology, is electrical impedance tomography. Electrical impedance tomography describes how ventilation is distributed inside the lung. On your left side, there is an homogeneous ventilation. On the right side, a non-homogeneous ventilation limited to the upper regions of the lung. Well, we can follow the distribution of tidal volume and the amount of aerated tissue non-invasively by electrical impedance tomography. And in this example, the effect of SIGs is studied in a patient, showing that when we apply SIGs, for the same level of PEEP, the end expiratory lung volume increases, as you see here at, at the end expiratory lung volume being higher than before the SIG. Again, we can use end expiratory electrical impedance tomography to study the effect of PEEP. And we have here in this patient 14 of PEEP down to 6. And you see that at 14 of PEEP, we have over-distension in some regions, while when PEEP goes lower than 10, we have collapse in the bottom of the lung. EIT can be used also to measure perfusion by injecting hypertonic saline in the central circulation. And in this paper, we used EIT to study perfusion and ventilation in COVID patients, and you can see here that we have a lot of ventilated but not perfused regions. Here again, you can see that we have patients with COVID-19 in which, on the bottom, extended regions of the lung are blue, that is non-perfused, and we have thrombi in the pulmonary artery circulation. As a matter of fact, what we found that survival is much impaired in patients with high dimers, that is with a lot of thrombosis, compared with, and low compliance, compared with the other patients. So imaging has evolved a lot in the last years, in the last 20 years, from simple chest X-rays to CT scan, positron emission tomography is just for research, but electrical impedance can be applied at the bedside. And with that, I thank you very much for your attention.